welcome Dr. Jeff Williams.
Welcome, everyone. It's good to see so many of you. I recognize a lot of faces in the crowd here. And one of our roles as physicians is to help educate our patients. And so this is an opportunity to try and learn a little bit about the disease many of you have and many of you are being treated for, or know someone who is being treated for this condition. And so I'm going to take you to medical school. So don't sweat. There's no exam after this. Some of you may know a little, and that's fine. I hope to raise the bar on that. Some of you may know a lot, and I hope that I can teach you something new today. So we're going to start here. You saw in the mime there that there is the eye here, and this is what we're going to be talking about is this little thin layer called the retina. And I'm just going to go back there because there is, so labeled there is that little word there called the macula. Most of the pictures and what we're going to be talking about is about that little part of the retina in the back of the eye. That's where your 20/20 vision is, and that's where all the action happens when we're treating macular degeneration. And we're going to see some more pictures of that, and I'll give you an idea of just how small that area is in relation to the rest of the eye. So the eye works very much like a camera. So there's the lens in the front, and when you hear about cataracts, that's all about replacing the lens in the front so that you can get a clear image to the back of the eye. But you got to be able to have a good, healthy retina or an undamaged film in order to see well. So out of this, we're not talking about the front in terms of cloudy media or lens problems. We're talking about the film in the eye. That's the back of the eye. And then if you want to go even further in that analogy, you can say, well, the USB cable to the computer, which is your brain, is the optic nerve. So we're just going to stick with the film on this part of the talk. And the point I want to make here is that the retina is much more complex than just this little film. So you actually start with about 100 million photoreceptors. Those are the cells that take light and translate it into an electrical signal. And within the retina, that 100 million actually gets transmitted by 1 million fibers back to the brain. So there is processing that goes on in the retina even before it gets back into the brain, even before it then gets interpreted by the brain as to what's going on in the outside world. And so that complexity is reflected when you look very, very closely at the structure of the retina. When you magnify the very center part of your vision, this little foveal dimple, this little pit here, that's right where your 20/20 vision is. If you look on the right-hand side of the slide there's 10 layers of cells and transmission neurons that are all processing the light signal, amplifying it, changing it, interpreting color, and then sending signals back to the brain. So this is why things like stem cell therapies and those kinds of things are still a ways away, because this is like what I call the telephone exchange. And so you can't just walk into a telephone exchange and say, hey, I got a brand new wire. I'm going to fix everything with this brand new wire. You got a whole telephone exchange there you got to replace. So the retina is complex. And when you look at it, that's what we see in the back of the eye. That's a normal optic nerve. The blood vessels are all the red lines. And then this very slightly yellowish, reddish center spot, that's the fovea. So when you look at this picture, this is a wide field picture. It shows almost the entire retina, edge to edge. So you can see that we're just talking about a little part in the center of the eye. That's where the action happens. So let's talk a little bit about vision loss and macular degeneration. Many of you know that there's dry AMD and there's wet AMD. Most of the vision loss actually comes from the wet because it's the more damaging kind. The dry is much more common, but tends to progress slower and tends not to cause as much vision loss, at least most of the time. There are a few cases where it is just as serious as the wet kind. And what is the cause? Well, we don't know entirely, but we do know that there's a lot to do with your genetics, that many of the genes in our makeup have a lot to do with what our risk factor is for developing this. And also there's many body factors that have to do with the blood vessels, so how likely you are to develop new blood vessels. And it may in fact be in part due to your genetic makeup of the blood system. Blurry vision is in the center of your visual field is typically the symptom of macular degeneration. But the other one that's careful to watch out is what we call metamorphopsia, or distortion. So that's straight lines, the Venetian blinds going curvy. Colors can change or become dim, difficult to read. And difficulty reading is kind of a good measure of it, because you have to have pretty good vision, about 20/40 on the eye chart, in order to be able to read well. So when your vision goes below that, it's difficult to read. And you may actually see some black spots centrally. So how is that depicted here? The children on the left is what the normal vision would be. And on the right, you can see that their faces are gone, and they're all kind of blurry and blotched out and kind of distorted and dark. And around that, you can still see the fence and the balls that they're holding. So that's the center part affected more than others. Well, I mentioned the genetic factors earlier, but really age is one of the big ones. And this is a condition that just tends to relentlessly get worse with age. And that's something that we're still learning how to fight. It does affect women a little bit more than men. Smoking is something that is definitely what we call a modifiable risk factor. So you can stop smoking, and that can make a difference. You can not start smoking, and that will make a difference. Sun exposure, that's something that you can alter a little bit, but that's not so easy. You can wear your sunglasses. If you have vascular disease, as I mentioned, high blood pressure and cholesterol, those things need to be managed, because when they're not managed, those are risk factors. If you are a Caucasian or lightly skinned and blue, lightly colored irises, that seems to be a factor. And obesity can be one of the factors. That probably comes back to the hypertension and cholesterol. So this graph here on the screen here shows the relentless part of the age risk. So you can see as you go from the 65 to 70 age group, it doubles when you go to the 70 to 75, and then it doubles when you go to the 75 to 80, and it just keeps ramping up very rapidly with age. And so we used to think, oh, well, this is entirely an age-related disease. That's how it got called, age-related macular degeneration. And it's only in the last 6 or 7 years that we discovered that there are genetic factors that actually have a lot to do with that curve. Now, I mentioned that there's dry and there's wet. The key thing between dry and wet, and you're going to see a few photographs of the difference here, is that dry simply means that there are no growing blood vessels. Wet is the kind that we treat. Dry, we don't really have a treatment for. So most of what we're talking about when we're talking about neovascular, or when we're talking about AMD, most of what we're talking about is the wet form. So I'm going to bring you back to the video that we saw at the beginning. I know it sounded or maybe looked a bit confusing. But what the video was showing there was the sidewalk and what happens on that sidewalk over a period of time. So I'm going to try and bring you back to that analogy of the sidewalk with this layer right in the middle of the screen there. It's labeled RPE. That's your pigment layer in the back of the eye. That layer is right up against the photoreceptors, that critical part of the retina that we talked about. That's where all the action happens in terms of translating light into the electrical signal that goes back to the brain. And that RPE layer has another layer underneath it called Brooks membrane. That's the sidewalk we're talking about. And so when we get to talking about cracks in the sidewalk and growing blood vessels and that kind of thing, just keep that analogy in mind. So here's the normal picture. And then we can see that there's a little thickening here. This is dry macular degeneration. This is an aging change. This is the sidewalk perhaps getting a little thickened over time. And you see that as yellowish dots in the back of the eye. And then this is where the cracks in the sidewalk start to develop. So now new blood vessels are growing through this thickened area. And now we have what we call wet macular degeneration. And over on the right-hand side, there's blood underneath the retina along with those yellowish dots. So now there's a big drop in vision. This is typically when the patient arrives in our office with a fairly rapid loss of vision and wondering what's going on, why can't I see? And then this is the situation that we're trying to prevent. So if nothing was done, what happens is these blood vessels continue to grow, they break, they bleed, and ultimately lead to a scar. So that white area on the right-hand side, that's just scar tissue. And now that complex retina with all of those interconnections is all replaced by this thick scar, and that's in a situation where we're no longer able to treat that. So we have to try and prevent that. And this is where our new therapies have come in so far in basically preventing this thick scar from forming. And this is much of the reason why we have had some success in treating this condition in the last 7 or 8 years. Now, how do we go about diagnosis? Well, we've shown you some pictures. So ophthalmoscopy, that's just the fancy term that we doctors use to keep you guys confused, because we don't like it when you know what we're really talking about. So we're really bad, by the way, just ophthalmologists in general. We have a language of our own, and we use it all the time, and we have to be very careful because nobody understands us if we talk our own language. So ophthalmoscopy, that's just looking in the back of the eye to see what's going on there. So we've talked a little bit about that, but I'm going to take you through some of the tests that you've probably already had or seen in the office and what they mean. So what do we see when we look in the back of the eye? Well, I mentioned some drusen, those are those little dots. Pigmentation is also another factor that's very important in this condition. It's been identified as being an additional risk factor. So when we look in the back of the eye, we're looking how many dots are there, how much pigmentation is there, because those two added together mean that there's an increased risk. So these kind of tables come out of the journals, and all of this, you can't read this in the back of the room, but when you have many dots and many areas of pigmentation, you can add those up and say, I think you are a risk score of 1, 2, 3, 4. When you get to 4, that means you have about a 50% chance of developing wet macular degeneration in the next 5 years. So we kind of have this little table in our heads, and we go, okay, this is the chance of you developing wet macular degeneration in the next 5 years. So then what's the next test? Something called optical coherence tomography. So this is light-based, so this is the good part, it doesn't hurt. The second part is coherence, meaning that we're measuring not just the time that it takes for the light to bounce back, but the light is referenced to another light, and those two then cause an interference signal, and that gives us very detailed images of the retina in the back of the eye. So when you get to tomography, that's like a cross-section. So it's literally as if you took the retina and you cut it out of the eye and you put it under a microscope and looked at it. And that's all just light-based, and it happens in a very short period of time with these machines, which are fancy-looking and they are expensive. And then on the left-hand side, you can see that's a cartoon, how the retina is structured. That little foveal dimple, that's where your 20/20 vision is. And on the right, that's a second-generation OCT scan, and you can see how similar they are. So we are able to see actual layers and structures within the retina. And it's a lot better than taking your eye out and putting it under the microscope, believe me. And if we did do that, this is what your retina would look like. So you can see the test and the structure of the eye correlate very nicely. So we get a lot of information from this test. And the top is the first generation. The middle is the second generation. Our third generation machines now are actually able to identify those 10 layers that we are talking about when we started. So now we're actually being able to look right inside the retina and see a little bit about what's going on structurally. So we can look at the structure. Now, when we're talking about wet macular degeneration, as I mentioned before, those are growing blood vessels. We need to know, are those growing, are they active, are they leakage? And this is the test that we do to tell that. So it's called an angiogram. So this means that you're taking pictures of blood vessels, and that means that we have to inject a dye into your vein. So the good part about this test is there's no x-rays involved. Again, it's all photographs and light. We inject a dye into a vein, and then we, with the camera, take pictures of those blood vessels, and this is what we see. So up top right there's a color photograph, and something doesn't quite look right in the center. And when you inject the dye, the blood vessels light up, and you can see that there's a bright white area just adjacent to the optic nerve right in the middle of the macula. So that is growing blood vessels right in the center. So this is another situation where the vision has dropped fairly quickly over the last few weeks, and that is why. So we now also have the ability to take those images in a very wide field arrangement, so we can see way out to the edges for many conditions. That's important. We can see blood. So up there in the top right, there's blood in the back of the eye along with growing blood vessels. And we can also distinguish that from dry. So here's dry macular degeneration. Here's the spots and dots in the back of the eye again. And these are areas where there are no growing blood vessels. Now, it looks white on the screen there, so you go, aha, that's leakage. Well, no, it's not. This is the interpretation part. This is where you have to go to school for a few more years to figure this out. Those white areas are actually not leaking. Those are areas where the pigment layer is now missing. So we call that atrophy, or just thinning. They're just disappearing. And unfortunately, this is the thing that we don't yet have a treatment for. And so you can lose vision from dry macular degeneration, sometimes just as bad as the wet. We also have another color of dye. We can look deeper into the back of the eye, underneath the pigment layer. And you see on the left-hand side, that's the fluorescein angiogram. So you see the retinal blood vessels. And on the right-hand side, there's a whole bunch more vessels. All those blood vessels are in the blood vessel layer called the choroid, which is underneath the retina. That's where the retina gets much of its nourishment. And this is part of where the action happens with macular degeneration and growing blood vessels. This is where they start, and this is where they come from. So we can look deeper underneath those layers of the retina and see the deeper blood vessels with that technology. And that shows us something slightly different sometimes. So here on the left-hand side, that's a fluorescein angiogram. That's leaking from a neovascular membrane or macular degeneration, the wet kind. You can see those retinal vessels. On the right-hand side, the retinal vessels kind of disappear. We're looking through that and behind that. And the whitish area, that's telling us that's exactly the area where the wet macular degeneration is originating from. And you can see it's slightly different from the fluorescein angiogram. So again, we have a little bit more information of where do the blood vessels start and where do they go. Now there's yet another technology of imaging the back of the eye. This is called fundus autofluorescence. So this is looking at the pigment layer now. And I mentioned the pigment layer, we're back to the sidewalk again. This area is very important for your vision as well. It interacts with the retina and sustains and nourishes it, and you need it just about as much as you need the retina. And the fundus autofluorescence is looking at that pigment layer and the health of that pigment layer. So the areas that look black on these pictures are, in essence, the pigment layer is dead. It is just not working. You'll also see pictures where they look a little bit bright, and that's what I would call, or we refer to as sick RPE. The pigment layer is kind of just starting to degenerate and disappear. And then there's areas that are sort of a middle gray. Those are actually the healthy areas. So I liken it to a light bulb. When your light bulb sometimes burns out, it goes a little bit bright and then boom, it's gone. So these pictures help us to show that pigment layer is getting a little bit brighter right before boom, it's gone. So when it turns black, those are areas that aren't functioning. Again, this is dry macular degeneration. So you can see the sick pigment cells that are right around the edge of the black ones. Those are the ones that are on their way to dimming and going out. And this is a correlation now between those two things. So on the left-hand side, you can see that's the fundus autofluorescence. Those are the pigment cells. On the right, where you see the white areas that sort of seem to go deeper down into the retina, even further back down, that's because the light can penetrate because there's no pigment blocking it. And you can also see in those areas that the photoreceptors and the retina is thinner. So those areas are damaged because they are no longer being sustained and nourished by the pigment cells. So you can see that one layer affects the other layer, affects the other layer. So if the choroid, which is the blood vessel layer, isn't healthy, that can degenerate. And if that degenerates, then the pigment layer degenerates. And if the pigment layer degenerates, then the retina can degenerate. So you can see that they're all tied together. It's like a sandwich. And all three of those layers are very important. So what happens with this condition? Well, over time, this is showing they're nicely drawn out here, but over time, they slowly enlarge and get worse. And this is where you'll often hear the patient comes in and says, "Doc, my vision is worse." And we look in there and say, "No, Mrs. Jones, your vision is exactly the same as it was last time." And they say, "Nope, you're wrong, it's worse." I believe the patient every time on that one, honestly. And the reason is I know that this process is going on in the background. And so our test might not show it, and our eye chart vision might not show it. But yes, unfortunately, this condition is grumbling along, I call it. It's slowly getting worse. And yeah, the vision probably isn't getting worse. The vision probably is getting worse, just sometimes not in a way that we can measure it. So before we get a little bit about treatment, and there will be another session that will get into a little bit more details about treatment, can it be prevented? The answer is to some degree, yes. A number of years ago, the Age-Related Eye Disease Study, or AREDS, was started. And this looked at, was there a combination of zinc and antioxidants and vitamins that could slow the rate of progression of macular degeneration? And you can see here on the slide, this was a 7-year study. The top line is if you took the placebo, so that's the rate at which you develop macular degeneration. And you can see the lines underneath it were lowered, and each individual component there was helping to lower the risk, so that if you took all the antioxidants and the zinc, that actually resulted in the lower risk of reduction of about 25% over that period of time. And so we could look at the category that you were in and see that, yes, you could be, your rate of progression was slowed depending on which category you were in. So the conclusion is that if you're in this condition, in this situation, where you had a few spots and dots or many spots and dots in the back of the eye, that you could slow this down. Now, this study was done with people who had macular degeneration, not with people who were healthy, never had any macular degeneration and started taking it. So we don't have information on that condition. These are the formulations that you would typically see in the stores. And then Dr. Ailes is going to talk a little bit more today about the eating healthy and that kind of thing. And I'm just going to touch on it a little bit because the diet is a little bit important, because there are things you get in the green leafy vegetables and so forth you don't get in a vitamin pill. We also know that fish is important because, again, they asked people that were in the study how many times they ate fish. And this was purely this was not experimental. This was just a questionnaire built into the study. And the people that ate fish more often in a week tended to have a lower risk of developing macular degeneration. And we think that that's because of certain types of oils in the fish. Now, I mentioned going way back that there's genetic variability to this as well. We're now just starting to tease out the idea that some of these vitamins, antioxidants, and so forth may work better for some people than others. We don't have it all figured out yet, but we're getting there. So that someday there may be a genetic test that tells you which one of these things you need to actually take. But for now, we're taking the shotgun approach that everybody gets everything. But in the not too distant future, we may be able to tailor this to you based on a genetic profile. We look forward to that. Unfortunately, the genetics are still very complex. This is a graph where all of those labels there are the various genes that have been identified to have to do with macular degeneration and their frequency. And there's at least 17 or 19 of them at this point right now that we know have an effect on macular degeneration. Some of them are good ones, some of them are bad ones, and it's the mixture of the good and the bad that tells you what your risk is. So again, it's a little bit complex, and we're still figuring that out, but we do know that there are certain combinations that are bad, other combinations that are protective. And so you can stratify that risk depending on which one of those genes you have, and at the bottom of the front of the slide, your risk is very low, and at the top and the back of the slide, your risk is very high, depending on that combination. Unfortunately, though, you can't just change your genes. You're stuck with what you have. So you have to make do with what you have. So this is the message that you need to try and protect and prevent that from getting any worse if you possibly can. So hopefully you aren't as confused as this poor friend of mine is, and you've learned a little bit about this today, and I will open the floor to any questions. Thank you. Yes.
I certainly appreciate you removing a film from the retina that overlaid my retina maybe a year ago or so, and I'm certainly grateful for that. What are the chances of the same thing happening to my right eye? My left eye is what you operated on. My right eye is fine right now.
Yep.
And so will this happen in a matter of a few years or not at all?
Well, that's a good question. So what you're talking about is what we call an epiretinal membrane, okay? And that's a film of scar tissue on top of the retina. And that's a condition that you can operate on. So it's happening in exactly the same spot as macular degeneration, but on top of the retina rather than underneath. That makes it accessible to us as surgeons that we can remove it. So the chances of it developing in the other eye are dependent on what we see or what we find in that other eye when we examine it. So it could be somewhere in the range of about 5 or 10% if you take everybody who's ever had that operation and add it all up. But we could probably lower or raise that number depending on what the examination of the OCT showed us. That would show us a very detailed picture. And if you had no scar there, your chance is very low. And if you already had a film, well, then maybe it's about 50% that it's going to be within the next few years that the other eye is done. So that's where the information, the very good predictive information, can come from the tests that we have. So, yes. Yes.
On how do you get that? How does that happen all of a sudden?
Macular holes, again, are happening in the same place. Your eye is filled with a kind of gel called vitreous, and that gel you're born with it. It is attached to and applied right up against the surface of the retina. And unfortunately, as we age, it will tend to collapse and degenerate and pull away. And 99% of the time, for most of us, it just pulls away and that's that. You get a few floaters in the eye, which are a nuisance, but not a problem. In a small percentage, like yourself, the vitreous gel just doesn't let go, and it pulls, and finally it rips it open into a hole. And again, that's something that we can operate on. We can go inside the eye, we can remove the gel, we can peel a little film around the edge of the hole to let it seal up again and put in a gas bubble, keep your head down, and that will seal up again. And you get most of your vision back, not all. But that is a repairable condition. But it happens exactly in the same place as macular degeneration, and not infrequently it's misdiagnosed or misinterpreted as being macular degeneration because the same thing happens. You get distortion, you get loss of vision, you can't read, and somebody says, oh, you got macular degeneration. Well, no, you need to do that OCT scan, and you see, oh, there's a gap there, that's a hole, that's something I can fix. Not just macular degeneration. So again, that's where our tests have been so helpful in figuring that out.
Is it also a matter of genes? Because 2 of my sisters, it happened to them too.
That's a really good question. And to be honest, I don't think that we've done a lot of research on the genetics of that condition. So the answer is we really don't know. But we hear that story frequently enough that, yes, I'm sure that there are genetics behind the connective tissues of the body, and that applies to the vitreous gel, that make some people more sticky and it doesn't let go, and other people is not as sticky and it lets go properly. So, yes.
Thank you.
You're welcome. Yes.
Having 2 sons who are 55 and at that age, do you recommend testing for eye diseases? They see their regular ophthalmologist, but
yes,
should they be asking for further testing?
That's a great question. So 55 is right around the age where those are the things that you want to start looking for, okay? And so I think that there probably isn't specialized tests that are necessary. I think that if they have an ophthalmologist who can look at the back of the eye and do that very first step, which is the ophthalmoscopy and just looking at the retina and say yes or no that you have those spots and dots, that's all you need at 55, okay? Where the specialized tests come in, I think, is when your risk factors start to go up. So if you're 65 and start to develop some spots and dots, maybe it's a good idea to have one of those OCT scans done and that kind of thing. And if you're 75, that again, maybe some more tests to look a little bit more closely. So the answer to your question really is, yes, it's good that they're getting it looked after. And secondly, no, they probably don't need specialized tests until maybe later on.
Just a question about lutein. What's the right amount of lutein that you need to take? And in what form?
Okay, that's a great. I get asked that all the time, and the answer to that is I have no idea. Okay? So the lutein story is rather interesting because lutein was never included in the first AREDS study. Okay? And lutein sort of popped up all on its own because we do find it is known to be in the retina. It's a natural component. It's part of what makes the little center spot in your retina a little bit yellow. And so recognizing that deficiency when they did the AREDS 2 study, they went back and they looked at lutein. Now, the dose was only 4 milligrams that they put in the second study. You can go out there and you can buy 25 and 50 milligrams and so forth, and you can take more. The study showed that the 4 milligrams was still effective and helpful in reducing risk independently for macular degeneration. So we know that it's important. How much? Well, at least 4 milligrams. Okay. So do you need to buy 25? Is 25 better? Unfortunately, nobody looked at that. We don't know. Okay.
Get those little spots before a hemorrhage.
Do you always get those little yellow spots you see in the retina before you get a hemorrhage?
Right. Or could you just have a hemorrhage with no previous indication that there was a problem?
That does happen, yes. That you with no previous indication, you can just boom have a hemorrhage, and usually what that means is there is something there brewing. Perhaps even new blood vessels can grow even without the yellow spots, and then poof, it happens. So those can be a big surprise. Yes.
Yeah, just awesome.
That's right.
Okay, so, thank you.
I did see there was a question way in the back there, so I just want to make sure I don't ignore the people way in the back as well. Thank you.
Can you tell me if the dry macular degeneration always stays dry or does it turn wet?
That's a great question, and I should have addressed that. So coming back to that sidewalk analogy and so forth, almost always the wet form of macular degeneration pops out of some sort of dry macular degeneration. So I call dry macular degeneration kindling, just ready to catch fire. So the question up here in the front was, can you get a hemorrhage without there being anything? The answer is yes, that does happen. But most of the time, there is some dry macular degeneration, which then turns into the wet kind. There are plenty of people who have the dry kind, and they go on and on and on and on, and they have dry macular degeneration for years or decades, and they lose a little bit of vision. That's probably the majority of people with macular degeneration. The small part is about 10% who flip from that dry to the wet, and then they get in big trouble, and then they in the office getting injections and treatment. So, okay, yes.
Does physical exercise influence the progression of the macular degeneration?
Yeah, not that we've been able to actually measure that. But I think it comes back to the overall health of the body and the health of the blood vessels and the lowering of cholesterol and those kinds of factors. Anything that helps the blood vessels will help the eyes. So when people ask about heart medications and all those kinds of things, should they be taking them? The answer is yes. Should they exercise? Yes. All of those things are good for the blood vessels. That's good for your eyes.
Thank you.
So, okay. All right. Well, I think we're running out of time. So thank you very much for coming, and I look forward to seeing more of you, and I hope that you learn more for the rest of the day. We've got some great speakers. Thank you.